Well, it's another way to.
It certainly doesn't replace surgery. There are many instances where you still have to have an open operation.
My second question was, from your experience, to both of you, how successful is surgery on children that, like my daughter, for example, her seizures began from viral encephalitis. 4 months after we left the hospital, they started. So we've had her evaluated for surgery, and currently the seizures are coming from multiple spots, both sides of the brain. So, I mean, is that something that you had experience with?
Yeah, so in that case, so first of all, just to take a step back, we're surgeons. We like, what's what we do? We operate. But we want to make sure, because what we're doing is very invasive, right? So we need to always step back and think, if we're going after multiple areas of the brain, that's very invasive. That's not, it's, to have the brain open here and there, this is not, it's not something that's very feasible. You got to look at, in those cases, if the seizure is coming from several parts of the brain, by a very comprehensive workup, we can maybe sometimes, in some instances, we can find that 90% of the time the seizure is coming from this one focus, as opposed to others. And in those cases, or maybe one or two focuses maybe close to each other, and those are cases, and it's one of the reasons why it's extremely important to have a multidisciplinary meeting. That's like UCLA and Radies and all these hospitals. One of the things that we do, we have a UCLA, myself, and 2 other surgeons. We have a team of at least 10 pediatric neurologists, neuropsychologists, and we go through each case one by one. Sometimes you get to a point where, the vast majority of the seizures are coming from this one spot. And in those cases, it may be wise to offer a surgery, but with the understanding that we're not curing all the seizures. So we have to, as surgeons, I think the onus is on us to be very careful as to when we suggest surgery. We're trained as surgeons, we always have a bias towards surgery, but we have to always make sure that we're doing what's best for your child. And you understand everything we do in medicine, there's nothing without risk, right? So the benefits have to outweigh the risk. Yes. Right? Always. So I can't speak particularly about your child because, again, we don't know the whole story, but and that generally is true elsewhere. Now, how we choose to treat it, whether it's through the traditional surgical approach, or through visual aids, or depth, or radiation, whatever it is that really is destroying that tissue, that's the second question that we should answer. Not the first question is this patient a surgical candidate?
Yeah, I agree. It's a matter of finding out where they're coming from and how frequently they're coming from those different areas. So not everybody's the same. And those are some of the more difficult pathologies to treat, when it's diffuse.
There's a question?
Yeah, my son has transmucin encephalitis. I know that's progressive, and he has benefit from ENS, the one that we're talking about, and it's been a lot of help, He also has EIG infusion every 3 weeks. And but my question is, like, he get this twitching, this is the worst part of it, the hand twitching. And the surgery that you were talking, I know he needs a bigger surgery, but can he benefit from that specific surgery, like pinpoint where the twitching comes from, and instead of going through the big incision, the big surgery?
Well, Rasmussen's encephalitis is a more diffuse hemispheric disease process, usually a little bit more than what a laser can do. That's a circumstance where typically surgery is a better option. Laser, there needs to be a focus of the seizures that's that's really measurable and that you can see and that the laser can get to. The ablation that a laser do won't be any larger than about 2 centimeters in diameter. You can pull that back along the temporal lobe, and so you can get it so it, maybe get 10 centimeters or 8 centimeters of the temporal lobe doing that as you back it up. But But the really diffuse process such as Rasmussen's,
Yeah.
it's traditionally it's been treated with surgery.
Yeah, Rasmussen, one of
Treated very well.
Yeah, there's 4 or 5 conditions that hemispherectomy is really the standard of care. One, Rasmussen, sometimes if you have a big stroke, usually as a baby on one side. Hemimegalencephaly is another one. Cortical dysplasia when it involves most of the hemisphere. And Sturge-Weber. Those 5 are really, and hemispherectomies are very effective at stopping seizures.
Yeah.
80% chance at stopping seizures. And Rasmussen's is one of them. Now, it's one of those things, the younger the child is, and usually less than 2 years and sometimes less than 1 year of age is probably the best time to do it, because the younger you are, the more the other side can take over. Obviously, you have to weigh the risks and benefits. You have to see how disabling these seizures are. It's not, it's not a knee-jerk reaction. You have Rasmussen's, you go to the operating room. It's not like that. You got to look at the seizures. You got to look at what's been tried. Is there anything else that you can try? In neurosurgery, we often say we don't operate on the scan. We operate on patients. So we don't. The scan is just one piece of the puzzle. We need to look at the child in front of us. How often the seizures happen, how disabling it is, how is it not letting you do the things that you want to do, right? And if all those things point towards surgery, and surgery can be done with acceptable risks, there will always be risks. So even this, we call it less invasive or non-invasive, there's risks to that too. Everything we do has risks in neurosurgery, and anyone who tells you there are no risks isn't being honest with you, right? So if that can be done, then and hemispherectomy is an option. Hemispherectomy is usually very, very successful. And with Rasmussen, that's on the 80% chance of being seizure-free, and or in the other 20%, there's a big chance of reducing those seizures by quite a bit.
So my son has had a traumatic brain injury and has left hemispheric infarct, and I think we're looking at a hemispherectomy probably in the next few months. But he also had a stroke on the right that has epileptic waveforms. Would he still be a candidate? Because it looks like the way his seizures are presenting, it looks like they're coming from the left hemisphere based on what he's doing. But would he still, what are the risks?
That's a great question. I'm starting a global study on hemispherectomy that's going to look at, I want to try to, what I was talking about earlier, how to develop a tool, a predictive tool that can be used to give you those that's exactly the question that I wish I can give you, an answer with certainty, right? And that's one of the variables we're looking at. So if the other hemisphere doesn't have, if it has seizures, that's different, because then you're doing what we call a palliative operation, which you're only treating the side that has seizures. The other side has independent seizures. So that's what we call a palliative operation. But from what I understand, it's called an interictal, and by interictal I mean it's the time when you're not having a seizure. So when we say ictal, we mean the time that you're having a seizure, what the brain waves look like. Interictal is between seizures. What you're asking is, there's abnormality on the other side during the time that he's not having seizures, but they're not seizures itself. So that's one of the things I'm looking at with experts from all across, not only U.S., not only Canada, but elsewhere. We're starting to study, and that's one of the things we're looking at. How much? No one will argue that if that was normal, that would give you better odds if the surgery being successful. What we don't know is how much that affects the probability of the surgery will be successful. My feeling is if the seizures themselves are all coming from that one side, the hemispherectomy will be successful. But I don't know that. I can't tell you that with certainty. And those are the questions I wish I could answer for you. Or everyone, a few years from now. Those are the things. That's the reason why we need to keep doing research, and not just being content with what we're doing now and saying, this is what we're doing, this is great, but how can we look to the future to make things better?
one more question. If the seizures are changing, like they're still settling, his traumatic brain injury was about a year ago, how much should I rush to do the hysterectomy, or should I let things kind of settle because they're changing constantly?
I would wait. Yeah, I would wait. So the seizure types are, the brain is a dynamic organ. Seizures are a dynamic process. Sometimes by waiting, sometimes you have multiple seizure types that then primarily become one type. And so every time, so when we say, when the character of a seizure changes, that fundamentally to us means it's a different area of the brain. The reason why every seizure looks different is because different parts of the brain are being activated. So if my motor area is being activated, I'm going to have jerks on the other side of my body, because that's what's connected to my motor. So when the seizures are changing, or when there's multiple, that's one of the clues that the seizures coming from different parts of the brain, or they're spreading differently. Their patterns of spread are different. So, just like, when you go get an eye exam, if you're, the prescription lens is changing, you kind of want to wait to see what your lens will be at before you invest in a new pair of glasses. It's kind of the same. I would suggest waiting, especially if they're changing so quickly, until it settles down, and then you have a better idea of where the seizures may be coming from.
Could they get worse and become, right now they're pretty focal, like, could they cross over?
So it depends. I mean, it depends on the...
Did he let you talk?
No, he didn't let me talk. I never said anything.
Go ahead.
I'm sorry.
Yeah, no, sorry. So can they become worse? Sometimes they can, but if the medications are for the most part controlling them, I will, no. We can,
I may talk to you afterwards.
okay, sure.
Thank you, guys. Thank you, doctors. Both of you. Awesome.